Today we'll be discussing about the FMGE Pediatrics 2K23 recall questions. The exam was held in 2 sessions, so let us quickly overview the questions that was asked from Pediatrics. So dose of vitamin A in an 8-month-old baby. The correct answer is 1 lakh international units. So let us remember age-related doses of vitamin A. So if it is less than 6 months, the dose is 50,000 international units. Okay. So if it is 6 months to 12 months, it is 1 lakh international units. If it is more than 12 months, then it is 2 lakh international units. Only one thing you need to keep in mind, that if the age of the baby is more than 12 months, but the weight is less than 8 kg, then we give half the appropriate dose, that is 1 lakh international units. Now let's see the next question. A 2-year-old child presents with fever, cough, coryza, conjunctivitis with maculopapular rash on the body starting from face. Most likely diagnosis is. So we have 4 options. All 4 are infectious diseases option. So here you see the 3 C's over here, right? Cough, coryza and conjunctivitis. Along with fever, and there is a maculopapular rash, and the rash starts from face. Here the answer to this question is measles. So few points we'll know from measles. First, measles belongs to paramyxovirus. Measles also known as rubeola. So what is the mode of transmission of measles or rubeola? It's droplet spread. Next, we need to remember that what are the clinical signs and symptoms that you get in case of measles, right? So on day 1, usually we get a prodromal features. There is going to be fever along with 3 C's. That is cough, coryza and conjunctivitis. From day 4 onwards, we'll have a rash, maculopapular rash, and it starts from the face. Most characteristically, it is post-auricular rash. Okay, so behind the ear. So day 4, we have the rash, and it starts from the face. Behind the ear. In case of measles, you get the complex spots. And in case of complex spots, it's a spots on the buccal mucosa. Sometimes you can get a spotter that it is present opposite the lower second molar. Okay. Now, 2 things more regarding measles. That is, in all cases of measles, to prevent measles, vitamin A is compulsory. And as I said in the previous question, what are the age-related doses of vitamin A? So most common complication of measles is otitis media. Most severe complication of measles is SSP. What is SSP? Subacute sclerosing panencephalitis. Usually there is a cognitive decline and myoclonic jerks in the child, and there is a history of measles infection many years back which we get from the mother. And even we now give isopronosine and calcium as therapeutic treatment for SSP, but still it is very bad prognosis. And the most common cause of death in case of measles child, remember, as pneumonia. So pneumonia can be a primary measles pneumonia or it can be secondary. In case of primary measles pneumonia, it is also known as giant cell pneumonia or Hecht's pneumonia. So also known as giant cell pneumonia. So these are the few one-liners that you need to remember for your next exams. Now coming to the third question. A 5-year-old boy presented with anasarca on electron microscopy. There is effacement of food process of podocytes found and is responsive to steroids. What is the diagnosis? See, it's a 5-year-old boy. Next is anasarca. So there is a generalized swelling of the body. And on electron microscopic picture, you get that it's effacement of food process and is responsive to steroids. So what is the diagnosis? The answer here is going to be minimal change nephrotic syndrome. So remember, minimal change nephrotic syndrome is the most common cause of nephrotic syndrome in case of children. So the age group is 2 to 6 years, and usually what we get in nephrotic syndrome, we have 3 features. One is massive proteinuria, massive nephrotic range proteinuria. Number 2, there is anasarca, and number 3, there is hypoalbuminemia. That is, albumin level should be less than 3. Previously, hyperlipidemia was also one of the parameters that was included in nephrotic syndrome. Now it is not included. So it is 2 to 6 years is the most common age group, and it is steroid responsive, that it is response excellent after we start prednisolone. Okay. And what happens in case of minimal change nephrotic syndrome? You do not need a renal biopsy, but in case you do a renal biopsy, on light microscopy you will not find anything. Only on electron microscopy you will find that there is loss of food process. So it is also known as podocytopathy. So you need to differentiate that whether this is a case of nephrotic syndrome or nephritic syndrome. See, if you are getting hematuria, hypertension, azotemia, it points more towards nephritic syndrome. Now, nephrotic syndrome can be primary nephrotic syndrome and secondary nephrotic syndrome. In age group 2 to 6 years, we are going to get the primary nephrotic syndrome. Okay, and the cause of primary nephrotic syndrome is usually idiopathic, and histologically you will find the most common cause is minimal change nephrotic syndrome, which is steroid responsive nephrotic syndrome. In secondary nephrotic syndrome, usually it is in extremes of age, that is less than 1 year and more than 10 years. And usually you need to do a renal biopsy and you need to rule out secondary causes. Like you need to rule out HIV, hepatitis B, hepatitis C, even some drugs like NSAIDs, D-penicillamine, etc. and even malignancies like Hodgkin's lymphoma. Okay, so in case of secondary nephrotic syndrome, you can have a mixed picture as well, nephritic nephrotic variant. Okay, and it is not going to be so much responsive to steroids. Now, before I go to the next question, I will just have a revision of the important definitions that are asked in nephrotic syndrome. So first is, as I said, what is the most important thing that you need to remember regarding nephrotic syndrome is the massive proteinuria or nephrotic range proteinuria. So what I mean by nephrotic range proteinuria? It is urine protein 3+ or 4+. Or if the urine ACR or the protein to creatinine ratio is more than 2. So urine ACR is more than 2. And you get the proteinuria more than 40 mg per meter square per hour. So is it visible? More than 40 mg per meter square per hour. So these are the 3 criteria to define massive proteinuria. Next, but we need to get this in 3 consecutive morning samples of urine. Next, coming to what is remission, if the urine protein is nil or it is stress for 3 consecutive early morning samples. And what is relapse? The child was in remission previously. Now the child comes to me for 3 consecutive days. The mother has seen that is either the urine dipstick showing me it is more than 3 plus. So it is 3 plus or 4 plus, or urine protein, urine ACR is again more than 2. So it is coming back to the criteria of nephrotic syndrome once again. So we know what is nephrotic range proteinuria, and we have understood what is meant by remission and what is meant by relapse. Next, what is meant by frequently relapsing nephrotic syndrome? So frequently relapsing means there is 2 or more relapses in the first 6 months after stopping initial therapy, or any 3 relapses in the 6 months or 4 relapses in 1 year. So you need to remember 3 things. First is the initial, that in the first 6 months you are going to have 2 or more. In any 6 months you are going to have more than 3, and in 1 year you are going to have more than 4. Right? This is the definition of frequently relapsing. Next, coming to SDNS, steroid dependent nephrotic syndrome. So what is meant by that? It is 2 consecutive relapses when all alternate day steroids or within 14 days of discontinuation of the steroid therapy. So very important. Either I am discontinuing the steroid within 14 days, or it is 2 relapses while on alternate day steroids. Now coming to what I mean by SRNS, steroid resistant nephrotic syndrome. So it is a lack of complete remission despite therapy with daily prednisolone at a dose of 2 mg per kg daily for 6 weeks. Please remember this criteria, and again this is different in children and in adults. So I am talking about pediatrics, so please remember it is 6 weeks. Okay, so revising these definitions once more. First, what is nephrotic range? It's urine protein 3 plus or 4 plus. The daily proteinuria should be more than 40 mg per meter square per hour, and urinary ACR is more than 2. What is remission? The child is coming up to me with urine protein nil or trace for 3 consecutive early morning samples. What is relapse? The child was previously in remission, now presenting with nephrotic range proteinuria. Frequent relapse. When the term frequent is coming, you need to remember in the first 6 months, first term is important. 2 or more relapses. In any 6 months, more than 3, and in 1 year, it is more than 4. What is SDNS? Steroid dependent nephrotic syndrome. It is either I am discontinuing the steroids within 14 days, the child is having relapse, or 2 consecutive relapses while on alternate day steroids. And lastly, the SRNS, steroid resistant nephrotic syndrome. That is the lack of complete remission after you have continued steroids for 6 weeks. Again, it's important, a very important one-liner for your future exams is 6 weeks. Okay. Now coming to the next question. A child presents with intra-orbital calcification and histology is suggestive of small round blue cell tumor. So gene involved in this condition is. It is a very easy question. It is telling me about one of the most common inherited childhood tumors. That is nothing but retinoblastoma. And the gene involved is RB1 gene, which is located on chromosome 13q14. Okay. So it is the most common primary intraocular tumor in children, one of the future one-liners which can be asked. What is the median age of diagnosis? It is 2 years. Just remember it is below 5 years. In Nelson it is mentioned that it is 2 years. You can just remember it. Below 5 years usually diagnose it. And it is RB1 gene. It follows the Knudsen's 2-hit hypothesis. So, and what is the chromosome? It can be a future question as well. Chromosome 13q14. And what is the most common presentation? We have the white eye reflex or leukocoria. So, leukocoria. Now, if leukocoria is not given in your option, the next best option is going to be strabismus or squint. In histology, you are going to get true rosettes, which is known as Flexner-Wintersteiner bodies, right? And remember, retinoblastoma is radiosensitive. But what we do, we give a good chemotherapy for treatment. Okay. Coming to the next question, and very important, contraindication to breastfeeding. Remember, nowadays the only absolute contraindication of breastfeeding is number one is galactosemia in infant or lactose intolerance, right? Galactosemia in infant, and if the mother is on chemoradiotherapeutic agents. Otherwise, all conditions are relative contraindications. Like HIV, previously we used to think that this is an absolute contraindication, but now this is a relative contraindication. And in HIV child also, we promote breastfeeding. So breastfeeding should be promoted to all mothers. And we need to stress, previously we need to stress on exclusive breastfeeding. We used to write EBM. Now we are actually stressing on MOM, that is mother's own milk, to be promoted. Okay. Next question, breastfeeding should be started within how much time after birth? See, according to the practices, we always say that breastfeeding should be started as soon as possible, within 30 minutes, according to the NRP protocol as well. But here the question was perhaps asked based on the WHO and the UNICEF protocols, which says that breastfeeding should be started within 1 hour after birth. I don't know the exact recall of all the options, but still it is within 1 hour. We need to start breastfeeding. Duchenne muscular dystrophy involves which gene mutation? So Duchenne muscular dystrophy, remember, it's an X-linked recessive condition. So what I mean by X-linked recessive condition? That means it is occurring in boys or males, and females are carriers, right? So that means boys are affected. And it is the most common inherited neuromuscular disorder. So most common inherited neuromuscular disorder. And you need to remember that the most common cause of death is respiratory insufficiency. Usually what happens in Duchenne muscular dystrophy, it's a DMD, right? So there we have the pseudo hypertrophy of the cuff muscles, and there is a proximal muscle weakness. So it's a proximal myopathy. Remember, there is pseudo hypertrophy of cuff muscles. Okay, and the most common cause of death is respiratory insufficiency or respiratory failure. Okay. So it involves which gene mutation? This dystrophin. The rest are not anywhere related with the Duchenne muscular dystrophy. And I'll just show you one picture because this picture is very classical, and you can be asked an image based question in the latter exams which you sit in the later sessions of FMGE. So you can see that the child is sitting on the floor and the child is trying to get up, right? And just follow these images from timeline 1 and to the last picture. The child is sitting on the floor and how the child is getting up. The child is taking the support of both the upper limbs and the child gets up. So this is nothing but, this is known as the Gower sign. And remember, Gower sign is positive in case of any proximal myopathy. So Gower sign is not specific for DMD. In DMD, you will get Gower sign positive. But Gower sign you are going to get in any disorder where there is a proximal muscle weakness involving the hip girdle. Okay, so this is a sign of proximal myopathy involving hip girdle. Okay. A child presents with wet loss cuff, X-ray shows hilar lymphadenopathy, CSF showed reduced glucose and predominant lymphocytes. Diagnosis is. See, in this option, you're already told about some prodrome symptoms like wet loss and cough. In case of bacterial, viral or fungal meningitis, wet loss and chronic cough is not going to be there. And you know, in a country like India, in one of the most important DDs in case of chronic cough is tuberculosis. So even if you don't know the rest of the question, if you don't know what does it mean, you can just answer pretty well that this is because of tuberculosis. X-ray shows hyaline lymphadenopathy, and CSF, very characteristic, it's predominant lymphocytes. If it was written predominant neutrophils, then I would have preferred bacterial meningitis. So both these points are very important. Reduced glucose with predominant lymphocytes. My answer is going to be tubercular meningitis. Now in any case of meningitis, right? So first of all, you need to suspect that a child is having meningitis. So there is going to be fever, and there are signs of raised ICT and meningeal signs. So what I mean by meningeal signs? So there is going to be neck rigidity, and we'll find there is going to be photophobia. If you flash light on the eye, the child will immediately close the eyes. And Kernick sign and Brudzinski sign, which are the signs of meningeal irritation, they are going to be positive. So Kernick's positive and Brudzinski positive. Okay. And there can be signs of raised ICP as well. That is, there will be vomiting, there can be papilledema, there can be blurring of vision, okay, and a false localizing sign, that is sixth nerve palsy. So in these cases, you can think that you can deal with a case of meningitis. Now, if there is no, you just divide in two options, that whether there is ICP raised, intracranial pressure is raised, or intracranial pressure is not raised. If there is no rise in ICP, you're going to do a CSF, and if my CSF is showing me that there is reduced glucose and cell count more and it's predominantly lymphocytic, then I'll think about tubercular meningitis. And if it is more neutrophilic, then I can think about bacterial meningitis. And if it is more increase in ICP, I'll prefer doing an imaging before an LP. And in case of tubercular meningitis, you're going to get endarteritis and basal exudates. So basal exudates, hydrocephalus, and endarteritis are very common features of tubercular meningitis. Okay. Question number 8. A child presents with hyperuricemia, that is, there is elevated uric acid, lactic acidosis, hypertriglyceridemia, that is, the triglyceride level is more, and hypoglycemia, enzyme deficient in this condition. So from the question itself, I think you can understand that you are dealing with an inborn error of metabolism and the constellation of features that are provided over here, that is more uric acid, more triglyceride, lactic acidosis, and less blood sugar. It points towards one of the most common glycogen storage diseases that we have. That is nothing but GSD type 1, also known as the von Gierke's disease. So once you know that you are dealing with von Gierke's disease, the question is pretty simple, asking you what is the enzyme deficient in von Gierke's disease. So the answer is option A, glucose 6-phosphatase. So let's quickly recap this glycogen storage diseases. So von Gierke's disease, the enzyme deficient, it is of two types, 1A and 1B. 1A is a glucose 6-phosphatase defect and 1B is translocase defect. Okay, and remember, in von Gierke's disease, you're going to get two organ involvement, hepatomegaly, renomegaly. So if you find kidney involvement, one thing you need to remember that we are dealing with GSD type 1. What about GSD type 2? First thing you need to remember that GSD type 2, it's both a GSD and a lysosomal storage disease. So deficiency of acid maltase and especially heart is involved. Very important cardiomyopathy you are going to get in case of Pompe's disease. Now, type 3 glycogen storage disease, we have the Cory's disease, also known as limit dextrinosis. The deficiency is of the D branching enzyme, and liver and muscle are the organs involved. Next, Ford Anderson disease is the branching enzyme defect. McArdle's, again very important, that it's a muscle phosphorylates defect and the muscles are involved. So if you are told in the question, a child presents with effort intolerance, or after exercise the child is feeling fatigued and weak. So one of the most common causes of glycogen storage disease is McCurdle's disorder and the deficiency of muscle phosphorylase. 6 is Her's disease, is liver phosphorylase defect. Tarui disease is phosphofructokinase, where we have the muscle and the RBC is also involved. Remember that, right? And lastly, remember Fanconi-Bickel, it is the GLUT2 deficiency. Fanconi-Bickel is the GLUT2 deficiency. So these are the few enzymes that you need to remember from GSDs, right? And remember, usually all the inborn error of metabolisms are autosomal recessive in nature. So it is autosomal recessive except type 8, which is an X-linked recessive. Cirrhosis is type 4. So type 4 GSD presents with cirrhosis. Hepatomegaly you will get in, just remember this, 1369. Cardiac and skeletal muscle involvement is type 2. And skeletal muscle mainly is involved is 5 and 7. So 2 is, I told you, it's Pompey's disease, where I have the involvement of the heart. And what are the ECG changes you get in case of Pompey's disease? We have short Peer interval, broad Curious complexes, and there is an increased association with WPW syndrome. Okay, so these are the few one-liners which you need to remember from glycogen storage diseases. Coming to question number 9. A child presents with sunflower cataract and Keyser-Fleischer ring in the cornea. So it's better known as the KF ring. So diagnosis is, so you are given 2 ophthalmological findings in a child: sunflower cataract with KF ring in cornea. So it is because of copper deposition. It is nothing but because of Wilson's disease. Just I am telling you this, one of the options is galactosemia. In galactosemia also you get cataract. So what type of cataract you get in galactosemia? It is known as the oil drop cataract. Okay. So see this picture. Usually KF ring you see by slit lamp examination, and it is because of deposition of copper in the Descemet's membrane of cornea. If you get a KF ring, it is 95 to 99% associated with neurological manifestations of Wilson or neuro-Wilson. So mostly related in 95 to 99% cases with neuro-Wilson. So usually there is a copper deposition in the basal ganglia. You will have choriothetoid movements, dystonic features, psychosis, etc. And 30 to 50% cases, it is associated with liver manifestations of Wilson disease. And in 10 to 20% cases, it may be asymptomatic. Okay, and this the ophthalmologist sees by slit lamp examination. So in the future exams, you can just be given a spotter with this ophthalmological image, and you can be asked that this is found in which condition? The answer is Wilson's disease. Which gene is involved? ATP7B gene. Okay, deposition of which element? Copper. More commonly associated with neurological features. Okay, so these are the things. So from Wilson disease, what are the things that you need to remember from Wilson disease? First, you need to remember that it is copper deposition, ATP7B gene defect. And the most common organ involved is liver. And remember this, that you get a Coombs negative hemolytic anemia in case of Wilson's disease. So you get direct Coombs test is negative in case of Wilson's disease. And what is the most common screening investigation you do in case of Wilson's disease? Remember, it's the serum ceruloplasmin level. Okay. And usually the serum ceruloplasmin level is low. You can also do it by seeing the 24-hour urinary excretion of copper, or you can do, in case of pediatric population, you can do a D-penicillamine challenge test. It's known as artamine challenge test, and then you measure the 24-hour urinary copper level. So if the question is screening test, the answer will be serum ceruloplasmin level. And the most definitive or the gold standard investigation in case of Wilson's disease is liver biopsy, where you quantify the amount of copper which is deposited. And in MRI, if you do, you get the giant panda sign. Now coming to the 10th question, vitamin deficient in xerophthalmia. So xerophthalmia, vitamin deficient is vitamin A. So here, this is a classic of Bitot spot you can see. So this is nothing but the Bitot spot. And now we'll see the classification of xerophthalmia. That is, XN is night blindness, whereas X1A is conjunctival xerosis. X1B, B for B, Bitot spot. X2 is corneal. So firstly you have the conjunctiva involvement, later on you have the cornea involvement. So X2 is corneal xerosis. X3A is corneal ulceration or keratomalacia, but is involving less than 1/3 of corneal surface. If the corneal ulceration is more than equal to 1/3, it's X3B. XS stands for corneal scar. XF, F for fundus, it's known as xerophthalmic fundus. So you need to remember all these things. Let's remember X1A, it's commonly asked, conjunctival xerosis, and B for B, X1B, Bitot spots. Suppose you're given this image and you are asked in your paper that it belongs to which gradation of xerophthalmia. So the answer is going to be X1B, which stands for Bitot spot, and it is because of vitamin A deficiency. And I already told in the question that what are the appropriate doses of vitamin A in children. Coming to 11, image is suggestive of. So this is a question of protein energy malnutrition. Now see this image, what you can find, you can see that the child is having edema, right? So there is edema and there is abdominal distension. So mainly my question is asking me that a condition of protein energy malnutrition where I am going to get edema along with abdominal distension. So it is nothing but kwashiorkor. So let us review this question once more. First, very important for your examination is the definition of severe acute malnutrition, the definition of SAM. And remember, any one of the following must be present. Not necessary that all the 3 criteria has to be present. It's severe wasting. What I mean, it's weight for height. Please remember, sometimes in your option, weight for height is not given. It comes like weight for age. So its weight for height is less than -3 z-score. Okay. So mid upper arm circumference is less than 11.5 centimeter, and bilateral symmetric edema in malnutrition. Okay. So any one of them should be present to call it as severe acute malnutrition. So we have marasmus and kwashiorkor, a table I have put up. In kwashiorkor, the age group is 6 months to 3 years. Marasmus, it's less than 1 year in younger children. Kwashiorkor deals with mainly protein deficit, whereas in marasmus, there is total calorie deficit. If in a picture you get edema and hepatomegaly with abdominal distension, more likely it is pointing towards kwashiorkor. There is loss of appetite in case of kwashiorkor, but whereas the child is very hungry, voracious appetite in marasmus. So edema with mental changes, apathy, kwashiorkor. And if there is the muscle wasting is severe in case of marasmus, so you'll get the prominent ribs. You can count the ribs even. So fatty liver, hepatomegaly, subcutaneous fat is preserved in case of kwashiorkor. So in marasmus, we say the child is alert, there is no mental changes, and it gives a baggy pant appearance. Whereas in case of kwashiorkor, we have a moon face, there is flecky pent dermatosis and flaxine in hair. There is alternate pigmented and depigmented hair. Okay, so which one is more what, sir? That is, which one is not good? Marasmus or Kwashiorkor. Both are bad. But if we have to compare between these two, then the Kwashiorkor. Why? Because there is mental CNS changes or CNS manifestations in case of Kwashiorkor. So another thing that you need to remember from severe acute malnutrition is what are the complications that we get in severe acute malnutrition. So complications in SAM, you can remember like this as shielded. This is a very well-known mnemonic. What does A stands for? Is sugar deficiency. Hypoglycemia. H stands for hypothermia. I stands for infection. EL stands for electrolyte imbalance. And what is the most common electrolyte imbalance that you get in a PEM patient is hypokalemia. So you get hypokalemia. Next we have D. D stands for DE rather, dehydration. And the last D stands for deficiency of micronutrients and even death. So when I am trying to manage a severe acute malnutrition, we need to have a look at all these points. We need to maintain the temperature level, the sugar. We need to give broad spectrum antibiotics. We need to monitor the electrolytes. We need to see about the fluid, and also we need to supplement with various micronutrients. Mode of inheritance in this pedigree. Look at this pedigree once. So here can you see this red denotes the affected male or female. First see that all the genders are affected, be it male or female, and no generation is skipped. So if all, irrespective of male and female, affected, and if I just have to name, this is generation 1, generation 2 and generation 3. So all generations are involved. So that means you are dealing with autosomal dominant condition. In case of X-linked recessive, it's only the males are affected, females are carrier. If there is skipping of generation, then I can think about autosomal recessive. But since there is no skipping of generation, all male and females are affected in all the generations, I am dealing with autosomal dominant mode of inheritance. Image is suggestive of. See, this is a histology picture. This is the right side and this is the left side. In the left side of the picture, you get a zoomed view. So this is nothing but the owl-eye appearance. There was a confusion in the recall that whether I am dealing with the inclusion bodies of cytomegalovirus, which also gives an owl-eye appearance. But perhaps this was given a malignancy question of Hodgkin's lymphoma. So in case of owl-eye appearance, we get in Hodgkin's lymphoma, and this cell is known as the RS cell or the Reed-Sternberg cell. Okay. So most common worldwide is nodular sclerosis. So most common type of Hodgkin's lymphoma worldwide is nodular sclerosis. And the most common subtype in India is known as mixed cellularity. So in all the variants of Hodgkin's lymphoma, usually you get CD15 positive and CD30 positive. However, in the nodular lymphocyte predominant variety, you get the CD15 negative and the CD30 is also negative. But in this case, you get the CD20 positive and CD45 positive. The worst prognosis is usually lymphocyte depleted and it is associated with HIV as well. Okay, so these are the few one-liners in relation with the Hodgkin's lymphoma. So coming to the question number 14, a child presents with abdominal pain and the following image is obtained. So this is the IVP spotter. And see this, usually the kidneys which should be located like this, they are more medially and the lower poles of the kidneys are almost fused. So I'm dealing with a congenital abnormality of the kidney. This is nothing but horseshoe kidney. And whenever you find horseshoe kidney, remember that we find in 1 in 400 live births, and it is very much associated with Turner syndrome. Okay. Following image is suggestive of. I'm not sure about whether genu valgum is asked in the question or genu verum. So I have put both the images. So can you see this? This is known as knock knee. So valgum, that is the knees are joined together. And if the knees are separated, we call it as genu verum or bow-legged. So following image is suggestive of. So you either, whatever be the question, you have to mark. If it is like this, you need to mark genu valgum. If it is like this, you need to mark genu verum. You need to remember whenever you get a child with genu valgum or genu verum, you need to rule out rickets. And suppose in one leg you are having genu valgum and in the other leg you are getting genu verum, it is known as wind-swept deformity. So it is known as wind-swept deformity. And wind-swept deformity, you need to remember that we need to rule out rickets, but we need to also rule out rheumatoid arthritis. Okay. A child presents with following X-ray. So you can see a circular thing, right? So if you see a circular thing in a chest radiograph, it is most probably this is a foreign body or a coin in the esophagus. If it is in the trachea, it will be a slit-like, not round. So esophagus, you'll get a round shape in chest AP, and in trachea you'll get a slit-like view of the coin. So this is just a very simple question on foreign body, esophagus, and what is the management include? The management will be esophagoscopy and removal. Like you can just apply your common sense also. Laryngoscopy, bronchoscopy, tracheostomy, all are dealing with the removal of foreign body trachea, okay, or the respiratory tube. So it is something to deal with the foreign body in the food tube. And the most commonly encountered foreign body in children is peanuts. Giant V wave in JVP is seen in. So giant V wave in jugular venous pressure is seen in tricuspid regurgitation. Even sometimes in case of tricuspid regurgitation, we get the giant CV wave. That is CV wave becomes joint and we call it as Lancisi sign. So Lancisi sign denotes giant CV wave. And it's a hallmark of tricuspid regurgitation. So I think you can appreciate the JVP waveforms. So we have got three positive waveforms, that is the A, C and V, and we have the X descent and the Y descent, the negative descents. So what is A wave basically? A wave is because of the contraction of the right atrium, right? So what happens when the right atrium contracts? Blood is pushed up into the IJV. What is X descent? So there is right atrium relaxes. So the pressure again falls. So you get a negative deflection. C wave is because of the closure of the tricuspid valve and the right ventricle contracts. Okay. Whereas V wave is filling. So the tricuspid valve is closed and there is a filling of right atrium against the closed tricuspid valve. Whereas Y descent, finally the tricuspid valve opens and the blood from the right atrium comes to the right ventricle. So you can be just given a spotter where you need to identify the A for A wave, C wave and the V wave, and some simple questions like where you find absent A waves, atrial fibrillation. Canon A waves, again a very important question. Canon A waves you find in case of complete heart block or in case of arrhythmias, ventricular arrhythmias or ectopics. Large V waves or CV waves, as I said, it's known as the Lancisi sign, you find in case of tricuspid regurgitation. And the Kussmaul sign is whenever the child inspires, there is a rise in the jugular venous pressure you get in case of constrictive pericarditis. So these are the few one-liners from JVP that you need to recall at the last moment. Extrinsic coagulation factor is, just let us briefly look at the coagulation pathway. So this is the intrinsic pathway, this is the extrinsic pathway. Extrinsic pathway starts with factor 7. And you can see the intrinsic pathway starts with factor 12. Next we have the 11. Next we have the 9. Next the 10. From the 10 we have the common pathway. Prothrombin gets converted to thrombin. Fibrinogen gets converted to fibrin monomer. Fibrin clot happens. And finally we have the stable fibrin clot. So in all these things, just remember factor 7 or the tissue factor is the extrinsic pathway. Rest all are intrinsic pathway, and from factor 10 we are having the common pathway where we have the intrinsic pathway and extrinsic pathway joins together. Right? So if I come back to my question, it's a very simple question that extrinsic coagulation factor is. So it is factor 7. And 2 extra H points for your exam. That is prothrombin time is a measurement of extrinsic pathway. Okay. Whereas APTT, that is the activated plasma thromboplastin time, is a measure of the intrinsic pathway. So if in the next FMGE session, if you're asked, prothrombin time can measure all the clotting factors except, so you know it very well that prothrombin time is a measure of the extrinsic pathway, whereas APTT is a measurement of the intrinsic pathway, right? So if you are having a liver disease or any condition like DIC, etc., where we have a PAN time prolongation, that is the elevation of prothrombin time and APTT, will have involvement of both the intrinsic pathway and the extrinsic pathway of coagulation. So this is in short the recall of FMGE Pediatrics. Kindly comment in the comment box if you have further recalls. Okay. Thank you.